Our next speaker will be Dr. Prithvi Mruthyunjaya, who will update us on current management of uveal melanomas. Prithvi.
Thank you, Dr. Murray, and thank you to the committee for allowing me to present, and to all of you, welcome to the Bay Area. These are my pertinent disclosures. So I'm going to leave you with some facts. Uveal melanoma is the most common primary uveal malignancy in adults. 90 to 100% of these tumors can be controlled locally, and there is still an unacceptably high metastatic disease rate in these patients. And the trend is now to try to treat tumors smaller before they grow too large in management. The current state of uveal melanoma care continues to evolve and improve. Diagnosis now is aided by the use of multimodal tumor imaging, including ultra-wide field imaging, enhanced depth imaging OCT, as well as angiography. We use clinical factors such as the tumor size, lipofuscin, and subretinal fluid to make a clinical diagnosis, and these traditional risk factors may predict the risk of growth, but we know now that not all growth is necessarily malignant. It's important for clinicians and also for patients to be able to estimate the risk of metastatic disease. And previously, clinical features or histopathologic features were used, and this is now moving towards a more molecular answer with chromosomal alterations and highly accurate gene expression profile testing. There are two effective treatments for uveal melanoma in the eye. The first is enucleation, where you have a 100% local tumor control rate, or radiation therapy, which gives us excellent tumor control and either given externally with proton beam therapy or with application of a radioactive source to the eye with episcleral plaque brachytherapy. We've recently looked at trends for globe-sparing therapy in these eyes, and over the past 2 decades, we've found that there's been a 14% increase in the use of radiation therapy with a concomitant 10% decline in enucleation rates, which is very reassuring. There are now treatments to improve globe-sparing techniques in order to enhance these outcomes. First is by using precision radiation planning, using orbital imaging like our radiation oncology colleagues. The second is improving techniques for safer and more effective choroidal tumor biopsy in order to obtain small specimen tissues for genetic testing. And finally, the active management of radiation retinopathy with the use of anti-VEGF agents, all of which we'll hear about in the subsequent talks. It is important for routine screening in the setting of potential metastatic disease because we know that 25 to 50% of our patients may develop metastases, most commonly to the liver. Focal and structural imaging of the abdomen is important, and at this point, there's no real utility in liver function testing. The National Comprehensive Cancer Network has recently put out risk-based screening guidelines that determine when and how patients need to be screened based on low, middle, or high-risk clinical and molecular features. There are some new experimental avenues in uveal melanoma that I think we should discuss about. The first is improved non-radiation treatments for melanomas. The problem? Treating small melanomas, especially in the macula, risk vision loss from the consequence of radiation therapy. AU011 is a highly targeted anti-tumor treatment developed by Aura Biosciences. It's a first-in-cancer type molecule, which is an inactivated human papillomavirus that is delivered into the eye by intravitreal injection. It has dual specificity engineering, where one end attaches only to the heparin sulfate moieties on the surface of the tumor, and the other is activated like photodynamic therapy with near-infrared light that induces oxidative damage and ultimately selective tumor death. In this phase 2 study, in patients that were entered that had documented growth of their choroidal melanoma, 88% were shown to have control of the tumor with this therapy with preservation of vision. Currently, a phase 3 study is being planned. The second area is preventing and treating metastatic disease, because the problem is uveal melanoma metastases still have no proven treatment. The main issue is the concept of micrometastatic disease, in which metastases initiate before the ocular tumor is even diagnosed, and subsequently the liver lesions then develop. Two strategies are used. One is adjuvant therapy, as seen with recent trials with a tyrosine kinase inhibitor called sunitinib, to try to prevent these liver metastases from occurring. And finally, directed therapy in order to control the disease when it does approach. There are off-the-shelf directed therapies that are used in metastatic cutaneous melanoma that have been promising. But what's clear is that the results are not the same in metastatic uveal melanoma, so new answers and solutions are needed. One option, as developed by Immunocore, under clinical trial, so TEBENTAFUSP is a bispecific T-cell redirection therapy molecule where one end attaches to moieties on the surface of the metastatic melanoma cell and the other end attracts directed T-cells to the tumor. So this very unique molecule may be one option for our patients going forward. In a recent phase 1 study, in which 19 patients who were heavily pretreated with metastatic uveal melanoma received this treatment, and overall survival was noted at 74%. A phase 3 trial is currently recruiting. There are numerous ongoing clinical trials, and we think it's important to work with melanoma medical oncologists to enter your patients into these studies to learn better options that may be available. I feel that we're entering a new era in uveal melanoma collaboration between retinal specialists, medical oncologists, patient-led organizations in biopharma, and in and between ocular oncologists and centers across the world. Thank you for your time.